Novo Nordisk has recently launched a weekly in India. Known as insulin icodec, this marks the first time a once-weekly basal insulin has been made available for clinical use. The target demographic in this region is immense. India currently accounts for 101 million people living with diabetes and an additional 136 million with prediabetes. For many, the primary barrier to treatment is injection fatigue. The psychological friction and physical discomfort of daily needles often leads to a phenomenon where patients delay starting insulin for 7 to 9 years after it becomes clinically necessary. A weekly alters the logistics of this therapy. By shifting the dosing schedule, the annual injection count for a patient drops from 365 to exactly 52. This reduction in frequency directly addresses the psychological resistance to insulin. By simplifying the routine, the therapy improves long-term adherence and stabilizes treatment outcomes. To create a once-weekly insulin, engineers had to overcome a major biological constraint. Endogenous human insulin and traditional analogs are designed to be rapidly cleared from the system to prevent the risk of fatal hypoglycemia. This creates a challenge. A highly reactive peptide must be modified to remain stable and release at a consistent rate for 168 hours. In this video, we will deconstruct the structural modifications of the icodec molecule, analyze the Phase 3A clinical data, and calculate the exact dosing protocols required to transition patients to this regimen. Extending the action of insulin to a full week cannot be achieved by simply increasing the concentration. It requires a complete revision of the molecule's structural biology. The design of insulin icodec begins with the human insulin peptide backbone. The first structural change is at position B30, where the threonine amino acid is intentionally omitted. Further substitutions are made to increase stability. Tyrosine at A14 is replaced with glutamic acid, while tyrosine at B16 and phenylalanine at B25 are both replaced with histidine. These modifications provide the molecule with increased resistance to enzymatic degradation within the body. The central mechanism for extending the drug's duration is acylation. A C20 fatty acid derivative side chain is attached to the amino group at the lysine B29 position. This acylation allows the molecule to interact with specific proteins already present in the patient's bloodstream. Through these specific edits, a short-acting hormone is transformed into a stable, long-acting receptor agonist. The C20 fatty acid side chain gives the icodec molecule a high affinity for human serum albumin, the most abundant protein in the blood. The insulin icodec binds strongly to this albumin, but the bond is reversible. This creates a circulating depot. Even at clinical dosages, insulin icodec occupies less than 0.05% of the total available albumin in the plasma. While bound to albumin, the molecule is pharmacologically inactive. This bond protects the insulin from being cleared prematurely by the kidneys. The molecules slowly dissociate from the albumin and move into the interstitial compartment. It is only here that they bind to the insulin receptor to lower blood glucose. By utilizing the body's albumin supply as a reservoir, the engineers have decoupled basal insulin from its standard 24-hour clearance cycle. To prove this mechanism worked, researchers conducted the Onwards clinical program. These 6 trials involved more than 4,000 adults, comparing once-weekly icodec against daily glargine and degludec. The primary goal was to prove non-inferiority. The researchers measured the change in HbA1c from the start of the trials against a strict margin of negative 0.3%. In trials such as Onwards 1 and 5, icodec did more than just meet the margin. It demonstrated statistical superiority. For insulin-naive type 2 patients, it showed an estimated treatment difference of negative 0.18%. Secondary endpoints were tracked using continuous glucose monitoring to measure time and range. The percentage of time blood sugar stayed between 3.9 and 10.0 millimoles per liter. Patients on the once-weekly regimen spent significantly more time in this target range, averaging roughly 1 extra hour per day compared to those on daily insulin. The data suggests that reducing the frequency of administration by 85% does not result in a loss of glycemic control. Transitioning a patient to a drug that lasts 168 hours requires careful planning. Because the molecule takes time to reach a steady concentration, clinicians must manage early hyperglycemia risks. For type 2 patients who have never used insulin before, the starting dose is simple: 70 units once a week. However, for patients switching from a daily basal insulin, we have to calculate the conversion. You first multiply that daily dose by 7 to find the weekly requirement. For the first week only, clinicians must add a one-time 50% loading dose. This compensates for the pharmacokinetic lag and ensures the patient reaches a therapeutic level immediately. If a patient was taking 20 units a day, their weekly base is 140 units. With the 70-unit loading dose added, their very first injection will be 210 units. After that first week, the dose is titrated in 20-unit increments. This is based on the average of the patient's 3 most recent fasting glucose readings. The goal of this titration is to keep fasting plasma glucose between 80 and 130. This initial loading dose and titration schedule allow clinicians to bypass the time it would otherwise take for a long-acting drug to reach steady state. While a weekly safety profile is similar to daily insulins, the most common adverse reaction is hypoglycemia, as seen in these clinical trial results. Due to the high U700 concentration of the pen and the long-acting nature of the albumin depot, clinicians must be wary of dosing errors and the fact that recovery from a low-sugar event can be prolonged. Patients also face the risk of hypokalemia. Like all insulins, icodec can cause a shift of potassium from the blood into the cells. A critical contraindication involves the use of PPAR gamma agonists such as thiazolidinediones or TZDs. When combined with icodec, these drugs increase fluid retention, which can trigger or exacerbate congestive heart failure. Even though the dose is only taken once a week, the 168-hour duration of action means that clinicians must remain vigilant regarding drug interactions and severe adverse events. The integration of acylation and albumin binding successfully translates a pharmacokinetic goal into a meaningful improvement in patient convenience. For the millions of diabetic patients in India, this once-weekly option addresses the physical and psychological barriers that have historically delayed essential treatment. Accessibility is a core component of this rollout, with the treatment priced at approximately 261 rupees per week in the Indian market. Quickly represents a redirection in the management of diabetes. By restructuring how the drug is administered, it offers a way to overcome the long delays in insulin initiation on a global scale.